My name is Kristina Schnitzer. I'm a fellow in public and community psychiatry at Massachusetts General Hospital and through the Department of Mental Health. Psychopharmacology is the study of the action of various drugs on the mind, brain, and behavior. We do this frequently by looking at chemical neurotransmission and how different neurotransmitters are interacting in our brain, and then the effects that drugs that we take may have on how those neurotransmitters interact. In thinking about medication and talking about it with patients, it's a helpful tool that we have. It's something to help them on their way to recovery, but it's certainly not without its limitations. The wide array of evidence-based psychosocial treatments that we have can be incredibly helpful in getting someone back on their feet. So things like cognitive behavioral therapy, CBT, supportive family, social work, supported employment, as well as somatic therapies like electroconvulsive therapy or ECT. All of these things can be a part of the pie. Medication can be a small piece of that pie, but for many people it's a very important piece and a necessary piece. A positive response to medication can be life-saving, life-altering, and I've seen that a lot in my work with patients with schizophrenia. Individuals with schizophrenia commonly suffer from what's known as positive symptoms. Delusions, hallucinations, paranoia can be really prominent and cause a lot of suffering for these folks. And so the medications we have are good at targeting those positive symptoms, and seeing that turnaround in someone is really incredible to see how much they're suffering, and if the treatment is successful, have that really be quelled. How do we choose a medication? We think about prior treatment responses. Was someone on a medication before that worked well for them, or more importantly, were they on something that they responded really poorly to? We want to think about the side effects that we know these different classes of medications may cause, and how those side effects can help or hurt the patient depending on what they are. Ease of dosing and monitoring is a big one. Thinking about the limitations that patients may bring. So is someone able to take a medication 4 times a day, or do they have a visiting nurse and they're only able to take a medication 1 time a day? That'll affect what drugs we prescribe and how often we prescribe them. Drug-drug interaction is really important. We'll go over some of those today. Comorbid conditions, so are they suffering from neuropathic pain, obesity, that could be affected positively or negatively by side effects in the medications themselves? And then also thinking about cost. Working with a patient, looking at what their insurance is this something that will actually be covered or that they can afford if not? We have kind of broad classes of medications. So we have antidepressants, anxiolytics, mood stabilizers, and antipsychotics. And those can be used alone or in combination to treat a variety of psychiatric disorders. For things like depression and anxiety, our first line is usually an antidepressant. For psychotic disorders, our first line is typically an antipsychotic. Mood disorders such as bipolar disorder may require a combination approach with a mood stabilizer and an antipsychotic. And there's a lot of intricate ways that the medications can interact and supplement each other that can be beneficial for the patient. So sometimes it requires some creativity. Key to starting a discussion of any new medication is thinking about or having the concept of shared decision making in your mind. And so that's where the patient and the provider share available evidence that both know. So the provider can often give more information about risks and benefits, alternatives to the drug, potential side effects when those might occur, how long they might expect to be on the medication before they experience benefit from it, or how long they may need to be on the medication in general. And the patient should be informed about all of these things before deciding with the physician to start a new drug. Side effects can differ from individual to individual, so the key is to really listen to the patient, have a shared conversation with the patient, and take it from them, what they're experiencing is real. The key is to walk along with them. For medications with known metabolic side effects, for example, we will do a lot of coaching around healthy lifestyle, behavior choices, diet, exercise, things that can really impact physical and mental health, but can also help when patients are experiencing the metabolic burden of some of our medications, in particular antipsychotics. We can also add on other medications to try and counteract some of those metabolic side effects. And in general, you can think about decreasing a dose of medication, switching to another medication in the same class, or another class entirely if some side effects are too burdensome for a patient. When thinking about medication adherence, there's really two big buckets of things you're thinking about: patient's attitude towards the medication, and then also the behavior of taking the medication itself. With attitude, you want to really explore, does the patient feel that this medication is necessary, that it's warranted, that it's actually treating something that they believe they have or can be helpful? And if that's not the case, it's a bit of an uphill battle from there. And thinking about behaviors, are there things potentially getting in the way of patients taking a medication? Are there cognitive limitations where they may forget to take the medication? Is it not built into their habit or part of their routine? Are they not able to access the medication due to copays or not being able to get it at the time that they need? So thinking really about those attitudes and then potential barriers, and as a physician working to educate the patient and also help reduce those barriers to the extent that you can by problem solving with them. Marijuana is a big issue that we deal with in our patients, particularly those with schizophrenia, and becomes very complicated because marijuana can exacerbate psychiatric, in particular psychotic symptoms, causing a relapse for patients who were previously doing really well. And it can also induce a lot of the negative symptoms, social withdrawal, amotivation, apathy, that you see with the disease process of schizophrenia itself. Use of marijuana can really compound that and make matters worse and make it really hard to treat or activate the patient to be involved in their treatment. Cultivating an honest relationship with your patient is really important so that they can feel comfortable sharing when they are using these substances, and you can problem solve around the other things. So when patients tell you that they're using substances, you want to talk to them more about why are they choosing to use that substance. Is it to relieve anxiety? Is it to feel some sort of escape or release? And when you're able to have that honest conversation with a patient, then you can discuss with them what are some other ways not using that substance that has other harmful consequences to target those issues that they're trying to get at. The question of tapering comes up often in some situations because a patient doesn't want to remain on a medication. They don't like the side effects associated with that medication. They may think that it's not working or want to try something else. And that's best done in collaboration with their provider so that we can take them off of that medication safely and replace it with something else if that's needed for treatment. We think about tapering safely and strongly recommend against patients just stopping their medications cold turkey, as some often do, because some of the medications we use can be really unsafe if stopped immediately. And in some cases, such as with benzodiazepines, it can be deadly if patients stop it cold turkey. While we certainly recommend people being on as little medication as possible that they need, sometimes medication can be life-altering and as we mentioned, life-saving. And I often tell patients that the goal of being on medication is to get back to feeling more like yourself, not less like yourself. And when these diseases can take hold and cause impairments that make someone not who they used to be, the goal with medication is to get them back closer to that person. It's my hope that over the course of my lifetime as a psychiatrist that we'll first get a lot better at understanding the disease processes themselves, what is actually going on and what is changing in the brain and elsewhere that's causing some of these symptoms that our patients are experiencing. So first I would hope that we get better at understanding the processes underlying the diseases themselves, and in doing so can then develop more targeted and precise treatments that have less side effects that we have to deal with now, that are more targeted to exactly the problem at hand. I think the field in general is a lot less black and white than people may think. We wish that there was a magic pill that someone could take that would fix everything. In reality, psychiatric diseases are incredibly complex. There's a lot of overlap, comorbidities, and in some cases we still are figuring out what is the disease process itself, what actually are we treating, and it can be really hard to say. So I think in psychiatry we live a lot in the gray and a lot in the details and the minutiae of people's lives, and it's figuring out how to help them move forward.
To take this course and learn about others, click on the link in the description and subscribe to this channel.